Dr. Amit Garg. Thanks, Amit, for accommodating KP. And he'll talking on lock and visual performance with rock solid rotational stability. All to you, Amit.
Thank you, everyone. Thank you, AIOS. Good afternoon. I will be talking about optimizing the performance of toric IOL. Cataract surgery has now become a refractive surgery where patient demands are increasing day by day. They are very high expectations. Astigmatism is pretty common and impacts the quality of vision. If we look at the literature, almost 1/3 of the patient have astigmatism more than 1.2 diopters. These patients may benefit from toric IOL, especially if we are planning for the EDOF or multifocal IOLs. Unconnected cylinder number may have the compounding effect. If one does not address the intraoperative astigmatism, almost 2/3 of the patients are left with astigmatism and the quality of vision is compromised. The burden of astigmatism, we have seen the problems, visual acuity is reduced, contrast is reduced, visual performance is compromised. Also the financial burden of making glasses is an extra thing, plus the glare and halos bothers the patient almost 2 times if we have a cylindrical number in the eye. Another thing is reading speed is less in mobile and computers, and negative effects of glare and halos obviously affecting the traffic lights. Spectacle dependence is more. There is a chances fall for elderly patient if we give them progressive glasses. Astigmatism can be addressed with toric IOLs or LRI. In the recent past, toric IOL have gained popularity. The main challenge is rotation of the lens in post-op period. The maximum rotation is seen in 1 hour of the surgery. Thus, the removal of the viscoelastic is a very important step. Now, the Technis toric is at the same platform as Technis. It has a squared and a frosted design to which help us to make a rotational stability. It gives us stability because of this frosted design. Landmark study with Technis toric has some highlights. It is based on the haptic design evaluation as well as the few other landmark features which we take, the cornea pigmentation, corneal vessels, and pigmentation on the iris also. Maximum rotation is 2.17 degree at 1 week. 100% of the eyes had less than 5% of rotation in 1 week, less than 1% absolute mean rotation. We all have been using Technis lenses, and Technis toric is also on the same platform, so that's why the optical quality and the rotational stability both are good. Technis is an excellent platform. Quality of vision does matter. 20/20 vision with sharpness, contrast is very important. Quality of vision, ability to see clearly even in low contrast conditions for your patients, and both the aberrations, chromatic and spherical aberration together, provides better quality of vision than simply reducing one or the other. Contrast is very good compared to other acrylic platforms. This is a glistening free lens, no glistening. Capsular phimosis is also non-existent because capsular phimosis can cause decentration of IOL later on, and which further decrease the quality of vision. Technis IOL provides sharp quality of vision, minimize the scattering of the light, and obviously the decreased vision due to IOL decentration is also less. Now the direct benefits of the IOL, toric IOL provides 94% at binocular uncorrected distant visual 20/25 or better. 88% of the patients achieve 20/20 monocular corrected distance visual acuity. 98% of the eyes achieve less than 0.75 diopter of residual refractive cylinder. Higher image contrast with Technis toric IOLs. At night time, this gives a higher confidence because of the no glasses. And almost 97% patient want the same IOL in the other eye with the same surgeon. To sum up, it has all the advantages of the Technis platform and much superior stability due to frosted haptic design. I would like to take this opportunity to invite all of you on the 50th annual conference of UPACon at Meerut from 29th November to 1st of December. Thank you.
Thanks, Amit. That's a wonderful talk. And I think Technis 2 has really stood to that platform of rotational stability. Just a quick question. Meanwhile, Dr. Anaga is there. And I would request all the speakers to just, we have paucity of time, another 5 more talks.
Yeah.
So respecting time, I think. When do you take these patients for re-rotation, if at all you have to take? What is your, the day of re-rotation?
Day of re-rotation, at least I'll wait for like first day follow-up. If a patient vision is less, I just cross-check everything. And if that is the rotation is there, I will do that day only.
On the first day?
Yeah.
Okay.
A dissatisfied patient and is reading well, and supposing it's rotated even 5-10 degrees, will you like to rotate it?
No,
I mean,
not at all.
what is the
Never.
Just by seeing that it is rotated, will you rotate it?
No, sir, never.
No touch technique.
Depends on the toric trim we have put in also. In low torics, it will not matter much to T3 and T4.
Yes.
If you have put in a T9
9.
and it has rotated by 10 degrees, the residual tonicity.
But even then, taking patient to another OT procedure, then the patient is satisfied, I think I'll not do that.
Actually, normally they don't rotate by about 10 degrees generally, but about 5-degree rotation is there in some cases, and therefore it depends on the attitude and the basically acceptability of the patient. Patients sometimes also don't want rotation or re-surgery on the eyes. They said we are quite well adjusted to it. Maybe we might wear small correction in our glasses. So some patients are very reluctant to undergo surgery to undergo surgery a second time when they are slightly incapacitated and feel that they can compensate easily with glasses.
Sir, I think addressing the re-rotation on the day one would again, if the lens is prone to rotation, rather than taking a week by the time the bag has a little contracted and, then So I think taking